I'm Luciano Sposato. I'm one of the stroke neurologists at London in Canada, Western University. I'm the head of the stroke program, and I run the heart and brain lab in which we investigate the heart and brain relationship, and we treat lots of patients with strokes and PFOs and other cardioembolic sources. So I'll give you a few seconds to read the disclaimer, and then we'll move on with the presentation. Okay, good. So these are my overall disclosures. And in terms of the epidemiology of PFOs and strokes, we know that around 17 million strokes happen each year worldwide, and 30 to 40% of them are considered to be cryptogenic. And PFOs may have a causal role in 25 to 50% of those cases. So overall, we think that 1 to 3 million cases of stroke each year are caused by PFOs. So this is a really, really important problem in terms of the epidemiology of stroke, and this is mostly because it involves strokes in young people who previously didn't have any specific treatment in terms of secondary stroke prevention. So the plan for today is to present 3 cases and give you some time to think about what you would have done in those cases if you had to treat these patients. So the first one is about PFO closure in patients who are younger than 60 years old, which is the typical scenario that we see in clinical practice. So this is a 24-year-old man who was driving, and he experienced sudden onset left visual field defect followed by left arm numbness 2 minutes later, and dense left leg, arm, and face weakness 5 minutes after visual symptoms onset. He came to the ED, and the NIHSS was 6, and his symptoms resolved in 2 hours before TPA was started. And then he developed an intense throbbing headache with photophobia and vomiting. He had a previous medical history of migraine with visual auras, with a presentation every 2 months. And he was started on aspirin in the ED, and he received a CT head and neck angiogram, which was unremarkable. He had no history of use of or misuse of alcohol. He has never smoked, and of course he lived independently at home. So so far, based on the description of the symptoms and his previous medical history, anyone would think that this is a migraine with aura, I guess, and I think there wouldn't be a lot of discussion about this. But this patient received an MRI of the head, and it showed that he had a multifocal ischemic stroke, as you can see here in this DWI MRI. So this was quite surprising. He was seen in another hospital, and then he was referred to my clinic. And on basic blood work, everything that was done in the emergency department was normal. And the hypersensitivity troponin T was 3 nanograms per liter, which is normal, of course. And the ECG showed sinus bradycardia. So this is a patient with a history of migraine with aura who presented with a quite typical picture of migraines with aura, with typically progressing symptoms, who was investigated with an MRI which showed a multifocal ischemic stroke on the right hemisphere, involving probably the right MCA and maybe the right PCA territory, although this is just in the borderline territory between MCA and PCA. So when we have patients who are young and have ischemic stroke, we have a predefined stroke in the young workup, which includes thrombophilia panel with APLA or anti-phospholipid antibody syndrome, or lupus antibodies, or lupus anticoagulant, protein C, S, and antithrombin 3. Deficiency, factor V laden, prothrombin gene 2210 mutation, And this is the basic one that we order for most of the patients. We test them for HIV. Now we are testing every young stroke patients for COVID-19. We investigate PNH, or paroxysmal nocturnal hemoglobinuria, which includes reticulocytes, LDH, and CBC. We have a predefined autoimmune diseases panel in which we look for different antibodies. In some cases, we look for Fabry disease, for example, when patients are young and have hypertension or kidney failure, or when they have the typical skin lesions. We look for MELAS with lactate, we look for CADASIL with Notch3 mutations, etc. So in some cases, when we are in the presence of multifocal strokes, we look for cancer-related conditions, or we look for occult cancers. Very typically, the D-dimer is very elevated in these cases, so that's what we use as the initial screen. And of course, we investigate possible toxic causes. In terms of vascular imaging, we look for dissection, vasculitis, or endocarditis. These are very common causes of multifocal strokes in young patients. For example, multiple dissections when there's an accident, or even spontaneous. Vasculitis is also a reason that may cause multifocal strokes at the same time. And endocarditis, of course, is another important reason. So all these investigations were normal in this patient. We did a transthoracic echocardiogram with bubbles, and it showed a right to left shunt following the injection of agitated saline contrast. And this was found at rest, which means that without the need of doing Valsalva, the patient did have a positive bubble study. Otherwise, the echocardiogram was normal, meaning that there was no left atrial enlargement or decreased ejection fraction or any valvular abnormality. So why are we using an echo with bubble? And this is, you can see here that when we compare a transcranial Doppler ultrasound or a transthoracic echocardiogram with bubble against TEE as a gold standard, both have a very good specificity, as you see here, or a very good sensitivity. In general, the transcranial Doppler, it's another option that we use in some cases. We don't use it that much in my hospital because it's easier to order a TTE. But the advantages of having a transcranial Doppler is that patients are very awake and they can do the Valsalva maneuver more easily than the TEE. And of course, you can also quantify the PFO size by quantifying the number of bubbles that are seen in the middle cerebral artery with a transcranial Doppler. In terms of TEEs, the good thing is that they can identify other structures in the heart that are not so easily identified with TTE and of course with transcranial Doppler, and they can characterize the PFO anatomy and the interatrial septum in a better way. For example, they can identify more precisely an aneurysmal septum or an interatrial or an mobile interatrial septum. So in terms of the recommended workup for imaging the heart, this is a position paper by the European Heart Society, which is quite interesting, and I think this is great in terms of how to investigate patients with strokes and possible PFOs. They recommend doing either a TTE or transcranial Doppler, both with bubbles. So if the TTE that does not show a PFO, then you can stop there. I'm sorry, if the TTE doesn't show a PFO, then it is recommended to repeat the study and do a transcranial Doppler, or vice versa. You can do a transcranial Doppler and then do a TTE if it's negative. If both are negative for a PFO, then we can stop there. And if any of them are positive, then it is recommended to perform a TTE. A TEE with bubbles, and the reason is that it will confirm the diagnosis of PFO It will help also to quantify the PFO size, and it will identify other high-risk features that accompany the PFO that can help making a decision in terms of whether to close or not to close the PFO. And those features that can be identified in the TEE are, for example, the aneurysmal interatrial septum, which is related to a higher risk of stroke, as well as the mobile interatrial septum. The number of bubbles can be quantified. And there are two features that are interesting, which are the Chiari network and the eustachian valve, which are which remain from the prenatal months before before we're born. The interesting thing is that the eustachian valve tends to direct the bloodshed to the PFO, and if there is a DVT or PE that releases some clot through the inferior vena cava, then those thrombi could go through the PFO more easily. And then the Chiari network is a structure that can lead to the formation of clots as well. And then based on the jet from the eustachian valve that pushes the bloodstream through the Chiari network, then those clots can be directed towards the PFO. So this is an example of a Chiari network that you can see in the right atrium, and this is a large clot that is impacted and could be fragmented with the bloodshed that comes from the eustachian valve. So this patient, going back to the case, he was having dinner 10 days later when he suddenly experienced speech difficulty lasting 90 minutes. He couldn't get the words out, but he didn't have any weakness or subsequent headache. So this was a clearly left frontal cortex TIA that lasted 90 minutes. He had a second MRI of the head, which did not show any DWI, any abnormal DWI lesions, but did show the previous stroke, as you can see here in the FLAIR sequence. So it is clear that this is a high-risk patient with a moderate-sized PFO who had a previous stroke, and 10 days later he had a recurrent TIA with a cortical distribution, which means that that the most likely mechanism is it's embolic. So I'll give you a few seconds to think what you would have done in this case. He's a young patient. He has a moderate-sized PFO, and he had a recurrent event 10 days after the first one. Okay, so what we did was a TEE to confirm that there was a moderate-sized PFO and that he actually had a PFO. And because we would not send someone for a PFO closure without having performed the TEE, and the reason is that there might be false positive tests. So we just want to be sure that if someone is going to get into the IR room, that we will be quite certain that there is a PFO to close. So in terms of future steps, we had to decide whether he would benefit from a closure or a medical treatment, right? While he had the second event, he was already on aspirin, meaning that the aspirin was not effective for preventing a recurrence. So evidence for what we should be doing with stroke patients with PFO comes from lots of studies, or there is a huge evidence that has accumulated within the last decade, I would say. There are at least 6 randomized clinical trials with short and long-term data, and there are lots of meta-analysis, observational studies. So now we do have quite substantial data to help our decision-making process. In terms of PFO closure, we have these 6 clinical trials, which I'm not gonna describe in detail because I guess you're quite familiar with them, but they have enrolled quite a substantial number of patients. As you can see here, there are overall around 4,000 patients that have been included in these trials. But just for make things easier and yeah, it's easier to remember. I will summarize everything here. As you know, there are at least 7 to 10 meta-analyses showing the results of these trials. I just picked up one, but I'll show you some others during the rest of the slides. As you can see here, there is an overall 60% reduction in the risk of a recurrent cerebrovascular event in patients with a PFO closure compared to no closure or medical treatment. There are no changes in the risk of recurrent AF or major bleed or any death, but there is quite a substantial risk of incident atrial fibrillation. This is a new atrial fibrillation that was not detected or diagnosed before the stroke or before the PFO closure. So that's around 500% increased risk, and this is a well-recognized situation. In terms of the size of the PFO, if you remember, this young patient had a moderate size PFO. There's some evidence suggesting that when you look at the overall benefit of PFO closure, for example, in this meta-analysis, there is a 45% reduction in terms of PFO closure. But if you look at high-risk patients with large PFO, that's even more significant. But when you look at small PFOs, the difference is no longer significant. And this is perhaps because of low power. But it's worth mentioning that if you look at data from the Gore reduced trial, which was the one who included some patients with small shunts or some other small PFOs, there was no interaction between in terms of the size of the PFO, meaning that the overall benefits seen in the trial apply both for patients with moderate to large PFOs and those with small PFOs as well. So I would say that, of course, patients with moderate to severe PFOs tend to benefit more, but saying or stating that patients with small PFOs do not benefit from closure is something that that we don't have enough evidence to claim. So overall, I would say that if there's a high clinical suspicion in someone who still has a small PFO, that doesn't mean that the PFO should not be closed. So in terms of medical treatment against or anticoagulants against antiplatelet agents, evidence comes from much weaker observational studies. Some of them are not even adjusted. Some of them or most of them are not randomized. So I would say that this 12% reduction in favor of anticoagulants against aspirin is something that we should just consider with a lot of caution. Indeed, when you look at another meta-analysis which looked exactly at the same question, and it was included in the AAN or American Academy of Neurology guidelines, this benefit for anticoagulants against aspirin was no longer significant. So this is something that it's again an unanswered question, and it would be difficult at this time to randomize patients to anticoagulants or antiplatelet agents, because we know that PFO closure works and prevents strokes, and patients should not be precluded from getting a closure. So this patient had an uneventful PFO closure. There was no residual shunt on follow-up echocardiogram, but at 3 weeks after closure, he developed palpitations, and he came to the emerge, and he was diagnosed with atrial fibrillation. So he's a very young patient without any structural heart disease who had a PFO closure following all the recommendations of the guidelines and the results of the clinical trials, but still he developed atrial fibrillation. So going back to the risk of atrial fibrillation, patients with PFO closure, we can see here, this is another meta-analysis. As I told you, there are lots and lots of meta-analysis for PFO closure. This one showed a 4-fold increased risk of PFO closure among the overall population at any time. But if we look at the first 45 days after closure, that risk seems to be even higher. But beyond 45 days, it's no longer significant. So most of us think that the risk of atrial fibrillation after PFO closure is higher within the first 45 days and then tends to fade off, and it's no longer significant. So to summarize what we know about post-PFO closure AFib, again, 4 to 5-fold higher risk of AFib after closure. Most of them are transient, meaning that they can revert it. They can be reversed with spontaneously or medically or with cardioversion. And as I said, the risk is much, much higher within the first 45 days, as in the patient that I just told you about. And only 0.1% of those AFibs are related to a new stroke, meaning that only 1 in 1,000 patients with post-closure AFib will develop stroke that is deemed to be caused by that AFib. So this is a very, very low risk of AF-related stroke. And interestingly, there is a hypothesis that patients with PFO tend to have more AFib than patients without PFO. And this is a very interesting study done in patients who were planned or were being investigated for pulmonary vein isolation. And all those patients received a TEE. And when looking at the TEE, only 18% of them had a PFO. But then when they went on to perform the procedure, 57% of them had a PFO. As you know, when a pulmonary vein isolation is done, the catheter needs to go through the interatrial septum. And if there's a PFO, the catheter goes through the PFO. So they found 57% against 18% diagnosed with TE, meaning that perhaps these patients with atrial fibrillation have a very high prevalence of PFO, and that's something that is sometimes missed in the TEE. So this is something to consider. Maybe patients with PFO have a paroxysmal subclinical AFib that is only diagnosed after the PFO closure just because of having manipulated the left atrium. And this is in the same line. This is the risk of incident atrial fibrillation in migraine trials of PFO closure. And as you can see here, there seems to be a tendency towards higher risk, but it is non-significant. And if you look at stroke trials, then the same numbers, between 4 to 5-fold increased risk. And in this case, it is significant. So my point here is that maybe patients with strokes and PFO have a very high prevalence of subclinical atrial fibrillation that, again, is diagnosed only after the PFO. Why would someone get AFib if they had a stroke, but would not get AFib if they had a migraine, when both treatments are PFO closure? So that's something to keep in mind, and I think it requires further investigation. So going back to this case, the patient received metoprolol 25 milligrams in the ED, and that converted to sinus rhythm. He was started on diazepam 120 milligrams daily. We stopped the aspirin and we kept him on the Plavix and started him on apixaban 5 milligrams. So this is a mistake. Apixaban 5 milligrams BID. 2 years after closure, there was no recurrence of atrial fibrillation. He received a 48-hour Holter and a 14-day Holter, which did not show AFib, and there were no stroke or TIA recurrences. So this is the end of the first case, and we're going to move on to the second case, which is PFO closure in patients who are older than 60 years old. So this is a 75-year-old woman with a 3-day history of worsening of a previously existing upper extremity and left extremity weakness and numbness. He had a previous medical history of a right basal ganglia ischemic stroke 9 years ago, a right subcortical periventricular stroke 3 years ago, a TIA 1 year ago with dysarthria, but no MRI was done at that time. and she had a history of hypertension and dyslipidemia, and she was intolerant to statins. She was on aspirin and clopidogrel, which was started 3 days ago when she had worsening of the left arm and leg, and she was on other medications for hypertension and dyslipidemia. He had no history of alcohol misuse. She was a non-smoker, and she lived at home independently. So this is the MRI that was done for the stroke 3 years ago, which shows that it's a stroke in the centrum semi-ovale, and the size of that stroke is 33 millimeters, which means that it is unlikely to be a lacunar stroke. There's a hyperdensity there that could be an artifact, because in the ADC maps, it doesn't look like it's something acute. So that's the other size in the coronal view. And the reason why I'm showing this is that sometimes axial slices could be misleading in terms of the size of the stroke. I usually go on to look at the size of the actual lesion in other planes, because that gives us the idea that this is not a lacunar stroke at all. This is a fairly large stroke that could be either related to branch artery disease, or it could be related to an embolic mechanism. So that was a previous stroke 3 years ago. She had a CT head and neck angiogram for the recent worsening of her symptoms, which showed multifocal atherosclerosis without significant stenosis. She had a TTE echo without bubbles, which showed a mobile interatrial septum, which was intact to color Doppler. And this is important to note. Doing an echocardiogram with Doppler does not exclude a PFO. We always need to order the echocardiogram with bubbles. The left atrial size was normal. Otherwise, the rest of the echocardiogram was normal, and the ECG displayed during the study was sinus rhythm. In terms of her basic blood work, it was normal with a troponin T of 15 nanograms per liter. And the ECG showed sinus rhythm with first-degree AV block. So she had an MR head, and the MR head showed, again, a multifocal ischemic stroke. As you can see here, left centrum semi-ovale, right centrum semi-ovale. They look fairly acute, and they happened at the same time. So again, we're in the presence of a multifocal embolic stroke in a patient who had a fairly normal echocardiogram, no history of AFib, and she has mild atherosclerosis of the intracranial vessels. So in terms of potential causes here, the multifocal narrowing of the intracranial vessels, which was fairly mild, it would be very unlikely the cause of two strokes happening in two different hemispheres at the same time. So that is likely not the cause. And for that reason, we should think about central embolic sources such as the heart itself or the aortic arch. The aortic arch looked well and didn't show any high-risk plaque, and so we were left with the heart. So in terms of future steps, what would you do next? Would you order more tests, or I don't know, would you do something else? Okay, so we ordered a 14-day Holter, which did not show AFib, but showed some runs of supraventricular ectopy. As you know, this is a risk factor for AFib. We followed up with her at 3 months, and there were no recurrent events. We ordered a second 14-day Holter and an echo with bubble, even if she was a 75-year-old lady. At 6 months, there were no recurrent events. The second Holter showed no AF, so we have a total of 28 days of monitoring. And the echo with bubble showed a moderate-sized PFO with a mobile interatrial septum. So, as you know, the presence of a mobile interatrial septum is a high-risk situation, and the moderate-sized PFO means that she's at higher risk of having a PFO-related stroke. So now that we have almost ruled out atrial fibrillation with a 28-day Holter, and we see that she has a PFO, and we're fairly sure that there are no other competing causes for her stroke, such as vasculitis, dissections, endocarditis, any valvular disease, or cancer. Would you go and close the PFO, or would you still look for more? Would you still look for AFib with more Holters? So we ordered a third Holter, an additional 14 days, and in the meantime, we calculated the ROPE score. As you know, this is a score that is used to estimating how much the stroke relates to a PFO as a causing mechanism, but it should not be used as a sole tool to decide for deciding who needs to have a PFO closed. And the ROPE score includes hypertension, diabetes, a previous stroke or TIA, being non-smoker, and the presence of a cortical infarct. Any of those items at 1 point, and then there's a huge weight for age. So for example, someone with an age of 18 to 29 gets 5 points, someone who's older than 70 gets 0 points. So her ROPE score was 2 because of her history of diabetes and being non-smoker, and that means that the chances of her stroke being related to a PFO was 0. So I had a very long conversation with her. She's a 75-year-old lady who had 2 strokes in the past, a TIA and a 4th stroke, and all of them look highly embolic. And we know based on the ESOS trials that we should not be using any oral anticoagulants for patients with embolic strokes of undetermined source. You know that even if someone has a PFO, that still qualifies as an ESOS. So anticoagulants was not an option for her, and then we were left with either aspirin, Plavix. Maybe we could switch her to Plavix. There was no evidence for supporting adding aspirin to Plavix, and the other option was a PFO closure, even if she was younger or older than 60. So what do we know about PFOs and people who are older than 60? We know that 35% of of elderly cryptogenic stroke patients have a PFO. So and this is quite similar to patients who are younger than 60. So it's exactly the same proportion, similar prevalence of PFO. And interestingly, the proportion of those PFOs that are moderate to large is exactly the same as, or quite similar to those of younger patients. So the prevalence of PFOs and the prevalence of high-risk PFOs in this population of patients who are older than 65 is exactly the same as the younger population. So it's very difficult to justify not closing a PFO when we have someone who's older than 65 and there's no competing cause. On top of that, when people look at the risk of, and this is a study from the group of Oxford, Peter Rothwell, and the meta-analysis of different studies, when they looked at the risk of stroke recurrence in terms of the age of the population, the higher the age, the higher the risk of recurrences in patients with PFO or cryptogenic strokes and the presence of a PFO. As you can see here, it's more significant for patients with increased age than those without increased age. So if we know that the prevalence is high, that the risk of those PFOs is as high as those for younger patients, and that the risk of a recurrence is higher in patients with a PFO who are older than the younger ones, it is very difficult to justify not closing a PFO. Of course, we can't do it systematically because there are no clinical trials with elderly populations. So we will have to wait for those trials to show results. But in the meantime, these patients still have strokes and keep having strokes. So we need to determine whether they will benefit with any other thing than just aspirin. So this is a small study published this year in which they compared patients with who were younger or older than 60 years, and they found that there were no differences in terms of stroke risk after PFO closure. Maybe this is because of a low number and being a little bit underpowered, but differences were non-significant. So we're stuck here without substantial evidence, and as I said, we still need to offer patients the best option to prevent more strokes. So what do the guidelines say? These are the AAN recent guidelines. They suggest that closing a PFO in someone who's older than 65 is an option, but these patients require prolonged monitoring, and that's the key. They still need very long, prolonged heart monitoring for looking for atrial fibrillation, because even if we don't find it after 28 or more days, they may still have atrial fibrillation. And the same thing for the European guidelines. They suggest that they should even get an implantable loop recorder for 6 months before a PFO is closed. So again, this is the MRI that we did because of the worsening of the symptoms. And as you can see here, this is another ischemic stroke that looks embolic. The CT head and neck angiogram did not show any abnormal findings compared to the previous one. And and as you can see here, this is I think this is inverted because it should be the other side. So we have a lady with 3 strokes, 1 TIA. They all look embolic. We look for AFib. There's nothing here. There's I'm sorry. Yeah, no. This is a new one that for which she came to the hospital. So lots of embolic events. No evidence of AFib. A moderate size PFO and an mobile interatrial septum. So would you close this PFO, or would you just keep looking for AFib? So a few days after being admitted, she had an ECG and it showed atrial fibrillation. So this means that probably the guidelines are correct, that we should look for AFib quite intensively for these patients to be sure that they don't actually have AFib, even if we think that the cause is a PFO. And the main reason is that if they receive anticoagulants, if they have to receive anticoagulants for the AFib for the rest of their lives, then it would not make sense to close the PFO, right? To close the PFO and again keep them on AFib. And a small comment or a short comment here about PFO closure and the risk of AFib in patients who are older than 65. This is another small study showing PFO closure in patients without history of AFib who were older than 55. So the ones who got a PFO closure, and please keep in mind that these are very small numbers, 28 cases here, 34 cases here. Remember, older than 55 without AFib. This group did not get a closure, no AFib on follow-up. This group did get a closure, and then 14% develop atrial fibrillation. So what does this mean? It probably means that these patients have perhaps subclinical AFib, but if that's the case, it would have been expected to see some AFib in this group as well. Or it may be that older patients are more prone to develop atrial fibrillation after closure. So that's something that we need to keep in mind for future studies, and we need to keep the eyes open to see if closing a PFO in people who are older than 60 results in more AFib than in younger people or patients. So the third case is also about a 74-year-old man with sudden onset right MCA syndrome with an M2 occlusion who came to the emerge. He had a history of hypertension and rheumatoid arthritis. He was not on antiplatelet agents at that time, and he was on medications for his underlying condition and amlodipine and ramipril for his hypertension. Again, no relevant social history. And That's the M2 occlusion, as you can see here in the CTA, and that's the fairly large stroke in the DWI imaging on his MRI. So he received a mechanical thrombectomy with a TK3 after a single pass, 3 hours after symptoms onset. Despite that, as you can see here, he did develop ischemic stroke, and there was no significant stenosis of the intracranial or extracranial vessels. He received an echocardiogram with bubbles, which showed an interatrial septum that was intact to color Doppler again, and everything was normal, including 48-hour Holter and a 14-day Holter. So what would you do next? We moved forward and ordered a TEE, which showed a markedly mobile interatrial septum with a positive saline contrast study demonstrating right to left shunt at the atrial level on resting, which means that it's probably large, and no significant aortic plaque or LAA thrombus. The basic thrombophilia screen was negative, and the investigations for occult cancer were negative as well. So again, we have another patient who received 16 days of cardiac monitoring and had a stroke, which had no evident cause, and but was clearly embolic because it was an M2 occlusion with a fresh clot that was removed. So again, we looked at his rope score. I think this should go here for hypertension. No history of stroke or TIA, non-smoker, cortical infarct here with a rope of 4, meaning that there were 38% chances that the stroke was due to the PFO. But something else that I would like to comment about the rope score here is that having a cortical stroke is really important in terms of how much the rope score changes in terms of predicting the relationship between the PFO and the stroke. So as you can see here, nothing changes between one and the other. The only difference here is that for the same person who's 74 years old, I changed whether there was a cortical infarct or not, and that the presence of the cortical infarct took the risk of a PFO-related stroke to 38%, and the absence took it down to 0. So that means that the presence of a cortical stroke here has a huge weight, as the age has. The other thing is that the rope score does not include multifocal stroke. For the first 2 patients that I showed you, the presence of a multifocal stroke was important for estimating that there was a cardioembolic source as the cause of the stroke. But here, I think that's something that should be tested in the rope score, because it may add more sensitivity to the results. And again, if you take a look at the same patient, exactly the same patient, but we just changed the age, it goes from 38% as in our patient to 88% when the age drops to 24. So that means that again, heavily weighted for the presence of a cortical infarct and age. So what are the clues for deciding whether to close a PFO or whether to investigate someone for a PFO based on the age? So when we have people who are younger than 60 to 65 years, we need to know that there is no, at least based on what has been studied, and as you can see here, there are 11 references looking at this. There's no infarct pattern that is specific for PFO. That means that when you have multifocal strokes or cortical strokes, it just tells you that it's embolic. It doesn't tell you that the cause of that embolism is a PFO. So that's something to keep in mind. And the other thing is that the presence of non-cortical infarcts can still have an embolic origin. So that means that patients with strokes in the corona radiata or the centrum semiovale or even deeper structures can still be cardioembolic, and we need to keep that in mind because deeper strokes do not rule out a cardioembolic source. And for those patients who are older than 65, if they did have a pulmonary embolism, or if they have, if they strained before stroke onset, or if they have a history of sleep apnea, or they had a wake-up stroke, those are features that have not been formally tested, but those are things that are known to be associated with PFOs or PFO-related strokes in observational studies. So something that we usually do in clinical practice as neurologists is to ask in which conditions the stroke happened, or how what were patients doing when the stroke happened. For example, if they were doing the laundry and they had to bend over and pick up the clothes, or if they were just lifting weight, or if they were helping someone who was moving. Those are things that are possibly related to straining or to increased pressures in the right atrium, favoring the right to left shunt. And of course, there are a few studies showing that wake-up strokes are related to higher risk of both PFO and paroxysmal atrial fibrillation. So this patient got a closure at 11 months. I'm sorry, he got an uneventful PFO closure, and at 11 months of follow-up, there was no residual shunt, no incident AFib, and no recurrent stroke or TIA. So to conclude, based on lots of recent clinical trials, meta-analysis, and other kind of evidence, it will be very likely that the number of PFO closures will increase with time. We know that PFO closure is safe and effective for reducing the risk of recurrent stroke in patients with PFO-related strokes. And the key here is to select the correct patient for closure. And that's where cardiologists and neurologists need to work together to properly select those patients.